It's my pleasure to introduce Greg Beatty, who will be our next speaker. Greg, actually, I think his picture's up here somewhere. Where are you, Greg? Right here. Greg and I literally have spent probably about 1,000 hours together over the last year working on Precision Promise. He is an expert in immunology and the application of immunotherapy to pancreatic cancer, and he's going to talk to us a little bit about how we might think about going about that in a new way.
All right. Well, thank you very much. Thank you for everyone coming today, and thank you, Diane, for the introduction. My goal today is really to provide a bit of the rationale as to why we're thinking about targeting the immune system for pancreatic cancer, some of the excitement that exists around using the immune system as a tool to fight cancer, but also many of the challenges that we are facing to kind of ground our understanding of where immunotherapy currently fits in pancreatic cancer. So the immune system is a key component of nearly every function within the body. Right? So it's important for cognition, for our brain function, for development. It's important in wound healing, right? And it's also important in defense, fighting bacteria and viruses. This is a key tool that we potentially have within our body, the immune system. And it's an important tool, particularly because of its diversity and specificity. Its ability, in essence, its ability to essentially seek out things that are going awry or changing within the body. This allows for, in essence, a personalized medicine that occurs within us. The immune system can also expand. So unlike receiving a drug on a daily basis, immune cells that live within our bodies can actually keep up with the pace of an infection. So essentially, the immune system acts as a living drug. It's also a very important piece of the immune system is its ability to remember, memory. Right? And this is the premise behind why we receive the flu vaccine each year, is to prepare ourselves for a potential challenge with the flu. And this is important in thinking about cancer as well. Can one be vaccinated and use that in a preventative setting to prevent the recurrence or even the development of a cancer? There are also some challenges that exist with the immune system, and that is its appropriateness and tolerance. Of course, we don't want the immune system to attack components of our body that are otherwise considered self. And so the immune system has to know whether or not something is foreign or something is self. And it must make a decision constantly as to whether or not to engage itself and become active. One of the key components of strategies that have been used to harness the immune system for cancer has been that these therapies, because of the ability of the immune system to remember, can lead to responses that lead to really long-term and durable outcomes. These are showing patients that have no progression in their disease over time. This contrasts to what we typically see with chemotherapies and radiation, where typically there is a recurrence that eventually occurs, that there's a response, but eventually that response is lost and there's treatment resistance that is seen. An example of using the immune system, and I want to stress that these are therapeutics that don't target the cancer per se. They're targeting the immune cells in one's body to educate them to attack the cancer. This is an example in melanoma where a patient had these cancerous lesions that can be seen here, and after treatment, you can see there's a delayed response, but eventually these responses can be quite dramatic. And this has been seen across several malignancies now, with the poster child of therapy being one that's called an anti-PD-1, PD-L1 therapy. This is really designed to take the brakes off of the immune system, allow for an ongoing response against the cancer to really have a good effect on targeting the malignant or cancer cells. And what you can see is that response rates, the ability to induce shrinkage and tumors, can be seen across a wide range of malignancies, cancers. But unfortunately, the success of this same type of therapy within pancreatic cancer has been lacking. Now that's, to make this point even more dramatic, in melanoma we've seen over time that various immune therapies have made significant progress. But when we apply these same type of immune therapies to pancreas cancer, we've not seen that same type of response. This has led to the efforts to try to combine immune therapy with cytotoxic therapies, chemotherapy, radiation therapy, in order to try to improve their ability to work. And while we have seen responses with these types of therapies, unfortunately, I would say that they're not necessarily that much better than what we're seeing with the cytotoxic therapy by itself. Now, there is one example where that may be different, and this is in a patient population that demonstrates a high propensity to develop mutations, changes within the DNA of the cancer. And those particular tumors appear to be a bit more immunogenic, meaning the immune system can recognize them and may have an impact on their growth. And here, there's early findings to suggest that those patients may actually be more responsive to immunotherapy. And there's a trial that was undertaken and sponsored by the Langone Foundation, and hopefully those results will become available, and we'll learn about whether or not this patient population really is one that can be targeted with immunotherapy. Now, the question might emerge, well, why is pancreatic cancer so resistant? And what are the key determinants that are important for getting the immune system to recognize and attack pancreatic cancer? Well, there are many things that the immune system must be able to do. There has to be some cell death in order to leak out some components of the tumor that will be recognized by the immune system. The immune system needs to be primed in order to know that it needs to go after these cancer cells. The immune system must then traffic and infiltrate into the cancer, and then it must recognize the cancer and eventually kill it. That's a lot of steps that must be taken, and it's the job of any cancer to try to derail this cycle. Now, we've tried as a community to use vaccines to try to provide the ignition fluid to getting the immune system working. By itself, I can say that it's not been effective. We've tried to release the brakes on the immune system, and the majority of cancers, of pancreatic cancer, I would say that this is also, as it's by itself, has not been effective. And we've even tried to infuse or to bring provide the CARs that would accelerate the immune response to pancreatic cancer. And again, by infusing immune cells that can recognize, they've been engineered to recognize cancer, and that by itself also has not been found to be efficacious on its own. And so what have we learned over time? We've learned that really, as Dr. Simeone made the point, monotherapy, so just a single therapy, is likely not to be the answer, that there's going to need to be a combination. We have learned that those patients that do have an immune system that appears to recognize components of their cancer tend to do better overall. And we're also beginning to learn that even chemotherapy by itself may invoke an immune response against cancer, and it's something that we need to still learn how to leverage it. But overall, I would say that there are many puzzle pieces that need to be put back together in order to make the immune system an effective approach to targeting pancreatic cancer. Now, there are many immune escape mechanisms that we think about in the laboratory. From a lay perspective, I would say cancer cells can develop ways to become invisible. They can use propaganda, so to speak, to try to convince the immune system to stay away. And they can also create a neighborhood that is effectively not conducive to an immune response against pancreatic cancer. And so what do we know about this neighborhood and what the microenvironment around pancreatic cancer looks like? Well, we know that the immune system is there. It certainly is there. There are cells, and you can see these brown cells surrounding these blue clusters of cells, and those blue clusters of cells is the cancer, and the brown cells is the immune system. But these immune cells that are present tend to correlate with a worse prognosis. So ironically enough, just having an immune response against the cancer isn't always a good thing. It's the flavor of that immune response that is important. We've also found that there are components of the immune system that are quite good. They're in purple here, with the cancer being in brown. But they tend to cluster. And their mere presence doesn't always seem to predict a better outcome. And this is perhaps due to the fact that If you have these immune cells over here and they're not attacking the cancer, which is over here, well, they're not seeing it. They're not engaging. They're not having the opportunity to recognize and kill those cancer cells. And so there are clear patterns that we've been able to identify with the immune system in pancreas cancer. There's clusters that take place, but often they seem to be trapped in this area, which we call the stroma. That's the tissue that surrounds the cancerous cells. These immune cells, when they do come in close contact with the cancer, though, they also seem to be excluded from interacting. They just can't seem to recognize the cancer. And it's not clear that all of these immune cells are even have the reactivity against pancreatic cancer. And there's emerging evidence to suggest that these cells may even have undergone a state of paralysis, that they need to be kind of revived in their ability to attack the cancer. And so what this means is that strategies to harness the immune system against pancreatic cancer will require ways in which to address this functional paralysis with the ongoing immune response. Now, the immune response in pancreas cancer does largely differ from what we see in other cancers, particularly cancers where immunotherapy seems to be working. So here's another example of the good immune cells that are in brown snuggling against the bad cancer cells, which are in yellow. And you can see there's quite a diffuse infiltration display of this immune system. But in pancreas cancer, you see lots of yellow cells, right? Yellow clusters. But you don't see much in the way of the brown, good immune cells. And when they are present, they seem to cluster in focal regions. And so this immune response that we see against pancreatic cancer seems to be slightly unique. So what causes the treatment resistance that we see in pancreas cancer, and why does the immune system seem to be excluded from interacting with cancer? Well, the laboratory studies that have been done have suggested that there's a component of the immune system called inflammation. Those were those bad immune cells that I was showing that are clustered very closely with the cancer cells. And so this has led to strategies to think about how do we deal with that inflammation. And there are, of course, many ways in which you could deal with any form of inflammation. You could try to deplete it, right, get rid of it. You could try to inhibit its ability to negatively impact the good immune cells. Or alternatively, you could try to say, perhaps I could harness that immune response for its potential benefits, given the fact that the immune system is quite pliable. And in the right circumstances, it can either promote cancer or it can inhibit cancer. And so these are the strategies that are being used, in essence, to try to condition pancreatic cancer from one that's not so responsive like melanoma is to an immune therapy, but from one that's unresponsive, and try to figure out how do we move along this nodal network? How do we condition tumors to being more treatment sensitive? Now, there are two major, I would say, treatment paradigms that have emerged from the laboratory models that have been studied. And one of those is to target inflammation in order to condition the tumor to be more sensitive to the cytotoxic therapies that we already use and are part of the standard of care for pancreas cancer. The alternative is to try to condition the cancer so that it's now more responsive to immune therapy. In general, I would say the major treatment paradigms are around trying to either deplete, inhibit, or redirect that inflammatory response that we do see within pancreatic cancer. One of the challenges that we do have within all cancers at this point is that we do have many immune-targeted drugs, but we don't know exactly how to put them all together. And there are numerous combinations that exist. And so as a community, scientific community, we've been thinking very strongly about how do we combine these. One of the strategies has to be, which is what Dr. Simeone was making the point of, is having smarter trials. Hypothesis-driven trials, trials that leverage concepts and either succeed rapidly or fail rapidly. We need to have good correlatives behind these trials, not just safety and looking at the effect of the drug in terms of its metabolism, but understanding how it's changing the immune system. We need to learn from every patient. This means incorporating tissue and blood-based biomarkers into studies and really leveraging the emerging technology that exists to really understand why patients sometimes respond, but why also some patients do not. And so in essence, this is smarter trials. So I'm just going to end here with making the point that there are many obstacles that the pancreatic cancer field is facing in terms of translating immunotherapy. I do think there's lots of excitement and promise, and there are emerging combination therapies that are being seen in the preclinical setting that I think will change the way in which we think about applying immune therapy to pancreas cancer. The challenges that do exist are the microenvironment that I was trying to make a point of, that neighborhood. The fact that the neighborhood is not homogeneous. Right? There are some areas where the immune system is and some areas where it's not. And we haven't talked about the clinical manifestations of pancreas cancer, how nutritional status and the location of the disease can potentially impact the capacity of the immune system to be effective. We do know that we can use the immune system to stimulate we can use drugs to stimulate the immune system in patients with cancer, with pancreatic cancer, and sometimes they correlate with better outcomes. But it's really the quality of the immune response that is really critical. Just inflammation within the pancreas can cause progression. And so having the right type of immune response is key. Strategies that will leverage ways in which to condition tumors to not only be more responsive to chemotherapy, our standard of care, but also other strategies for immunotherapy I think are going to be quite important moving forward. And to do this is going to require combination therapy. And that's that puzzle piece of putting back all the pieces to make the immune system most effective. And so I would be remiss without recognizing many of the funding partners that have supported us, as well as other laboratories around the country. And I just want to thank you for your attention. So the numbers, I mean, we're talking about 1% of the patient population. So gathering that, this is a new finding, right? And it catapults off of, springboards off of the fact that this gene mutation, right, or set of mutations has been seen in other cancers and only has now recently been applied to pancreas cancer. So this is an active area of investigation. Trying to capture those patients is a challenge, right? Of knowing where they are, and you may have one patient out of 100 that come through. And so that requires really a team effort. And I think this is where the field is moving to be able to capture that patient population and understand. My prediction would be that those are patients who do have a good immune cell infiltrate. And what you're doing is you're leveraging that good immune cell response and tipping it over the edge to allow it to have an effective outcome.
I guess the question is, got the same KRAS there, cytokine, all that.
Yeah.
So how is it? That seems like it's
Well, yes, it's. I would say that one of the challenges here is the fact that so the community would say that one of the reasons why this gene or set of genes is very important is because it changes the signature of the cancer. It makes it more identifiable by the immune system, right? But we don't know that's the case in pancreatic cancer, and more to learn on.